My name is Hossein Jahedi. I am a cancer biologist at the University of Auckland. I work in the Auckland Cancer Society Research Center. We've got a few projects happening in our lab. So I work in the cancer discovery, cancer modeling and discovery lab, which is headed by Dr. Emma Nolan. We have different kind of streams of our lab, but one of the main things that we do is we develop patient-derived organoids, cancer organoids. So what we do is, for example, for breast cancer patients, when patients undergo mastectomies, some patients donate a small portion of their tumor that is not required for any diagnostics or clinical protocols, and we bring it into the lab. We kind of digest the tumor to get all the cells out, and we grow these cells in a matrix with media, and these cells over time self-organize into 3D structures that are quite similar to the patient's tumor. And this is quite important because then we're able to study cancer and understand their behaviors, how they function, but we can also test drugs on these organoids to see how the patients may respond to drugs that they will be receiving. So it can act as an avatar, really, for cancer patients. We work quite closely with both clinicians and other scientists. So in hospitals, we have collaborators that we work closely with. These can be oncologists. Laird would be a person, for example, that many people will know that I do collaborate with. We collaborate with pathologists, so Emma mainly, but then myself. We collaborate with Dr. Reena Ramsarup, who actually presented in the breast cancer SIG last year as well. So she's a pathologist that helps us with obtaining the samples and helps us also look at them and kind of develop new hypothesis to study. We also collaborate with other researchers. So this can be researchers within the University of Auckland or sometimes across the country. And we're trying to do the same thing for lung cancer as well, to start a new collection of these patient-derived organoids. And with these ones, we particularly are focusing on advanced lung cancer patients, and we want to see whether we can follow these patients through their kind of journey, and also to see how we can help them. So what I mean by that is once we develop these organoids, we can treat them with different drugs, like 5 to 10 drugs, maybe more, depending on how much material we have. And these can be the same drugs that the patients may be receiving in clinic. And so in cases where it's really hard to tell what the patient is going to respond well to, and when oncologists have to just make decisions based on their experience, we may be able to provide an extra line of evidence that this patient may be more sensitive to this drug compared to this other drug. And of course, it's not going to be 100%, but at least it can provide another line of evidence. So that's what we're trying to do with the lung cancer project, a little bit more than the breast cancer project, I guess. So I think once we establish, in terms of lung cancer, kind of the protocols, and we show that we can do this, then we would definitely want collaborators in that area to then expand and see whether we can get the project into clinical trials of some sort across the country. That project, we also collaborate with a health economist who is just across the road from us in the other building of MFHS. We want to kind of interview at least a number of patients to see what value this may provide for them. Because obviously, living cells can be a little bit, I don't know, for someone who doesn't know what it means, and you're asking them to take some samples from them and grow their cells somewhere else, can be a little bit stressful. So we want to understand, if we do this, what values does it have to them, not just in terms of saving money, but also whether it adds any certainty, whether it provides any other values to them that is good, because at the end of the day, we want to also argue that this is something that we can provide to everyone, and that giving the patients a better drug in the beginning is also cost effective, rather than having to give them a drug that doesn't work. They're going to have the side effects, and after a few months, I have to receive a second drug, and the cost of that can actually be more than doing this for the patients. So we're trying to kind of get ahead of the curve and see if we can obtain some information both from the patients and also see whether it's a more cost-effective way of treating cancer patients, just because it's really hard to know how patients are going to respond to certain drugs. Let's try to understand the role of one of the immune cells in how breast cancer patients respond to chemotherapy. And so we try to understand the relationship or the interaction between this specific type of immune cell and cancer cells. As we know, most immune cells, they're protective, and they protect us from infections, they protect us from various things. But in cancers can be quite clever communicators. And it's like, I give this example of watching a TikTok video that is addictive, and it goes into your algorithm, and then you just keep watching and getting fed information that may not be good for you. So they can be like that. So they can train the immune cells to behave in a way that benefits the cancer rather than us or our own body. So I'm trying to understand the relationship between macrophages, which is a type of immune cells, and cancer cells, because what we found is that cancer is able to retrain these macrophages to protect them against chemotherapy. And we try to understand how that relationship happens in the lab. I think it's really like a privilege, really, to be doing what we do. That's how I look at it, because it's all the stuff that we know is stressful, long hours, funding is not, but at the end of the day, I do want to go to work, and I think that's quite a privilege.